Assalamu alaikum class. Today we are going to start another topic which is screening for diseases. In majority of the examiners take epidemiology and screening as one component, and usually when your SEQs are formulated, one question comes from both the sections. But it depends totally on the choice of the examiner. Sometimes they take epidemiology and screening separately, and you can get separate questions from the component 1 and component 2 in the SEQ paper. So, it basically depends on the examiner's choice. I will recommend you that you should study the components of epidemiology and screening from your textbook, which is recommended because most of the questions are scenario based, and you must have a better knowledge for the understanding of the scenarios and attempting the questions in a right way. So, we are going to start with screening for diseases today, and our learning outcomes of today's lecture are that we will be dealing with the concept of screening, that what do we understand by the screening. Actually, I will give you an example that screening is basically applying a screen through which a total population passes, and when the total population passes through this screen, the diseased population remains on the top of the screen and the healthy population goes away from the screen. So, actually, it is a diagnostic procedure, or it is a diagnostic examination which separates the diseased population from the healthy population, in that population which is apparently healthy and they are not suffering from signs and symptoms. So this is basically the concept of screening, and we should know that how the screening tests differ with the diagnostic test. What is the concept of lead time? And actually, while going through the screening, the basic concept of an epidemiologist is to buy lead time. We will be dealing with lead time. We will be discussing that what are the aims and objectives of screening, what are its uses, what are its different types, and what are the criteria of a disease which should undergo screening in a population, and what are the criteria of a test which should be run as screening test in a diseased population. So, it's a very comprehensive lecture, and you have to pay attention to the contents of this lecture. So, moving forward, let me give you an example of an iceberg phenomena. As we all know that the diseased population which comes to a hospital or a clinic is totally different from a population which is residing in the community. And when we take the community which is coming towards the clinics and the hospitals, these are those individuals who have symptomatic disease and they present with signs and symptoms. The doctor does the diagnosis, he gives the treatment, and this population goes back in the community. And this is population which is apparently present in the community because of the presence of the sign and symptoms for which he or she is seeking treatment. But a larger population in the community stays in the community and does not go to seek the healthcare service provision because they are symptom free and they are present in the pre-symptomatic stage where the disease occurrence has started, but yet the sign and symptoms have not developed. As public health physicians, our concern is to deal with these pre-symptomatic people who are present as the submerged portion of the iceberg in the community, because this portion and the people who are affected with the signs and symptoms, they will go and seek healthcare service provision. But this population, which makes a larger population, which is the submerged portion of the iceberg, stays in the community and they pass through a critical time period of diagnosis and lead into the complications and higher morbidity associated with the disease. So, as public health physicians, we are concerned with this portion rather than this portion, because the clinicians will take care of this portion and we will take care of this portion, which is the pre symptomatic disease. We all know that in pre-symptomatic disease, we have the patients who are in the subclinical stage, who are apparently healthy. They are carriers, they have latent infection, and they do not have the sign and symptoms. So they are present in the community, they are maintaining the chain of transmission of infection, and they are not seeking healthcare services because of the lack of sign and symptoms. So, actually, what happens with the natural history of a disease is that the biological onset of a disease starts here, and there is a longer time period before the sign and symptoms appear in a person. And this time period, when when the biological onset of disease has already started, and the symptoms have not yet occurred in that particular person, this phase is known as preclinical phase, because in this phase there are no apparent sign and symptoms present in that particular person. Once the symptoms appear, this the person enters into the phase which is known as the clinical phase, which presents with clinical sign and symptoms. And sometimes the patient remains silent in the community until and unless the symptoms get exaggerated. So he goes towards a clinic for the diagnosis or a hospital for the diagnosis. And after the diagnosis, the treatment gets started. So again, there is a gap between diagnosis and therapy. And once the treatment is started, then it can end up in uh, either the recovery, or it can result in morbidity, or it can result in complication, or it can result in death. So outcome can vary depending upon the type of diagnosis, depending upon the therapy when it is started, and it also depends upon the adequateness of the therapy. Fine. So, with these things, we as public health physicians, what do? We say that before the onset of the disease, we should give health education, and we should give specific protection as a mode of primary prevention, because we want healthy people to remain healthy, and we want them to have specific protection against certain diseases which he or she can encounter in future, in which we give immunizations, we give health education, we give specific promotions of healthy exercise, healthy habits, etc. and etc. So once the patient enters into the biological onset of disease, now we enter with the phase of secondary prevention, where we see that the early detection and screening are most important, because with early screening and early detection, we can reduce the course of illness of a patient, we can reduce the morbidities associated with it, and we can reduce the disability limitation. Fine. So this is the secondary phase where we promote screening and early detection, and then adequate treatment if the diagnosis is done. And then once the diagnosis when once the therapy is given and there is disability production, or there is some comorbidity associated, then we apply the tertiary prevention, in which we say that the disability should be limited and rehabilitation services should be provided to the population. So these are the basically methods of prevention, or the modes of prevention which we apply on the natural course of a disease in a population. And we have adequate time here in the preclinical phase, where we can say that with early detection of the disease, we can reduce the comorbidities, we can reduce the complications, and we can change the course of the outcome of the disease. So, with this, how we define the screening is that the search for unrecognized disease or defect by means of rapidly applied tests, examinations, or other procedures in apparently healthy individual. So actually screening is done here where the population is apparently healthy, and we run screening tests. They can be laboratory tests, they can be examinations, and then we can detect them early before the appearance of the sign and symptoms in that particular group. So this is the concept of screening. So, the search of unrecognized disease in apparently healthy individuals is known as the process of screening. This is also known as the early detection of hidden disease, in which, in the healthy population, you apply a screening test and you diagnose a patient um, as early as you can before the appearance of the sign and symptoms, um, and you save time that this particular person will develop sign and symptoms and will go to the clinic to treat the disease. You diagnose it, this particular person beforehand. So you want to diagnose the hidden disease in the community by applying the screening tests. What is the difference between screening and periodic health examinations? Initially, in the early phase of the development of public health, what was done that the periodical medical examinations were done of different communities, and after regular intervals, the community people were asked to undergo certain tests, and they were diagnosed, and everybody would, even if they are healthy, they would come to the clinics, and they will have periodic health examinations, and detailed examination would be done for that population. But what do we do in screening? In screening, the public health physician goes to the community and then apply different tests in the community to identify the hidden disease which is present in the community. So there is a difference between the two approaches. Screening has a wider application because with limited resources, you can go and cover a larger area, a larger population, and you can cover lots of diseases in one process of screening. Screening is relatively inexpensive because sometimes you screen population only through a simple test. For example, if you want to screen the school health children for the refractory errors, you will only be needing the Snellen's chart, and you can screen them and you can detect the refractory errors presence in the school children. So it is usually inexpensive, and it does not require much resources, as the most expensive diagnostic procedures are usually not applied in the community. Invasive procedures are not applied into the community. Fine. Another important advantage of having screening is that it reduces the physician's time, and if the physician will do the periodic health examination of the whole community will be coming to the healthcare services provision, and they will be coming to the clinics and hospitals, and the physician will be thoroughly examining them for all the systems and for the detection of all the diseases which are prevalent in that community. But if screening is done and then patients are referred to the physician, definitely the physician time will be reduced, and it will help in the early detection of the disease in the due course of time. Fine. So the other thing which is that makes screening test different from a diagnostic test, let me emphasize here that screening test is basically applied in the population to identify the hidden disease in that population, but a diagnostic test is applied on an individual who is suffering from sign and symptoms and who has come for the final diagnosis of the disease. So, screening test is done on apparently healthy population who are present in the community. The public health physician goes there, the doctors goes there and screens the population. But the diagnostic test is applied on those who are sick, who are suffering with sign and symptoms, who have come to healthcare facility for the final diagnosis and treatment. Screening test is done on the groups which are present in the community. It is done on the larger group. For example, the whole community will be screened for a certain disease, or a whole occupational group is screened for a certain occupational disease, or some other groups, vulnerable groups, are screened, but diagnostic test is applied on a single patient, and it is done for the diagnosis of the disease in that particular patient. There can be multiple diagnostic tests. Fine. Screening test, usually results are arbitrary and they give a final uh, value that this particular person is suffering from this disease. He may have to undergo different diagnostic tests as well to confirm the diagnosis. And it actually points out that this particular person can have this particular disease for which this test is applied. But for diagnostic tests, sometimes the diagnostic tests are not useful in their alone capacity, and um, they have to be done in multiple phases, and sometimes multiple tests are applied for the final diagnosis. Moving forward, the screening test is basically they are based on one criteria or cutoff point. There is a cutoff point that if the community which passes through the screening test, if it passes this threshold value, then they will be diagnosed as diseased population, and if they will be far below this threshold value, they will be labeled as healthy population. But the diagnostic criteria but the diagnostic test only cannot be beneficial for diagnosing of a disease, and they are evaluated on the number of signs and symptoms with which the patient is presented, and a large number of laboratory findings are required. A large number of diagnostic tests are required to make the final diagnosis. Screening test is usually less expensive, and sometimes only the clinical examination can help us to screen the patient, and diagnostic tests are usually more expensive. I will give you an example that in the corona pandemic, the detection of fever was a screening test which separates the diseased population from the healthy population. But the diagnostic test for the coronavirus was the PCR, and which was done through nasal swabs or throat swabs, etc. So basically, screening test is done on a larger population to differentiate between those who are diseased from the apparently healthy population, and diagnostic test is basically done on the diseased population or diseased individual to have a final diagnosis. So usually screening tests are less expensive and diagnostic tests are more expensive. A screening test does not make a basis for the treatment because they have this particular patient who is screened now. He has to undergo the diagnostic test, and once the confirmation of diagnosis is there, then it makes a basis for the treatment. So, after diagnosing the patient who has passed through the diagnostic test, it makes the basis for the treatment. The screening tests are basically applied by the government authorities or by the health agencies or by the international organizations. But the diagnostic tests are basically originated from the healthcare physicians to whom a patient reports with the sign and symptoms. Moving back towards the natural history of disease, as I have already mentioned, that this is the biological onset of disease. For example, we all know that the development of coronary heart disease starts with the early intake of fats and triglycerides and cholesterol, even in the childhood. But the signs and symptoms appear after a certain period of time, and there is a long period between the appearance of the sign and symptoms from the onset of the biological onset of the disease. As we all know that I have given you an example of the development of coronary heart disease that in early childhood, if the child is taking junk food and he's obese and he has diet which is rich in cholesterol and fat, early atherosclerosis starts in the early childhood. And with the passage of time, this atherosclerosis gets aggravated, and after a certain period of time, once this child reaches the age of 40 or 50 years, the atherosclerosis is so vast that it blocks the vessel, and there is ischemia to the coronary muscles, which can lead to the ischemia, or it can lead to the myocardial infarction. So the biological onset of disease and symptoms, the time between them is a longer time period, and once the symptoms appear, then the patient goes towards the doctor, and then there is diagnosis. Again, this there is a gap between the appearance of the sign and symptoms and the diagnosis, and once the diagnosis is done, then the treatment is started. So why we are interested in screening is because we want to detect the disease before the appearance of the sign and symptoms, and this is the time when we can detect the disease by the process of screening. And this time period when the original diagnosis would be done after the appearance of sign and symptoms, this time is known as the lead time. And this lead time gives a wider time period to a physician in which the early treatment can be started and early diagnosis can be done. And in apparently healthy individual, you can detect that this particular person is going to suffer with this disease in future. So you start your treatment, you start your preventive strategies, you give health education, you take adequate measures, and you can prolong the course of illness, and you can prolong the time period for the appearance of signs and symptoms. This time period is known as the lead time, and this is very, very beneficial for the community. So basic purpose of screening is to have adequate lead time in which, with the early detection of the disease and early treatment of the disease, we can reduce complications, we can reduce disability, and we can improve the survival rates, we can reduce mortalities in the community. Fine. So what are the uses of screening? Uses are that we can detect cases, we can identify the population who is going to have a particular disease in apparently healthy population, and this is known as prospective screening. We can apply case control measures, we can apply disease control measures, and this is actually known as the prospective screening. We can use screening for research purpose, we can use screening for the detection of disease, and then we can do health education measures for increasing the public awareness about the prevention of disease. Fine. So let's discuss them one by one. The first example which I will be discussing with you is the example of case detection, which is known as perspective screening. And perspective screening means that you want to diagnose the patient. You want to diagnose the patient in an apparently healthy population by applying certain screening tests. The most important example of prescriptive screening is the diagnosis which is done in the neonatal screening. For example, once a newborn is born, you can have multiple tests. You can identify the inborn errors of metabolism. You can screen him for the congenital dislocation of hip. You can screen them for the congenital malformations which are present, and this will help us to identify the different cases in the apparently healthy newborns, and we can increase the lead time, and we can do early detection, and we can go for early treatment. Fine. So this type of screening is known as prescriptive screening. Another example can be that in a population of young females who are between 30 to 50 years of age, you go and um, you ask for the you tell them about the palpation method for the detection of the breast cancer, and only by doing self-examination they can detect the cases, and they can go for the early treatment. So these are types of case detection and the prescriptive screening. Moving forward, the other type of screening is known used for the control of disease, and this is known as prospective screening, in which people are examined for the benefit of others. For example, during the corona pandemic, screening was done with the detection of the fever in the normal, apparently healthy population, and the population which was having fever was screened. They were separated and they were quarantined so they cannot infect the others. So whenever you screen a population for the purpose that you will segregate this population from the rest of the healthy population so you can control the transmission of disease, is known as prospective screening, and this is done for the control of the disease. Moving forward, another type of screening can be done for the research purpose. And initially, for example, if you go in a community and you do initial screening, and we identify that how many of them are having blood pressure, will give us the prevalence estimate. Once the screening is done, after calculation of the prevalence, another phase of the screening is done, in which we can find out the emergence of the new cases of hypertension in that community. So we can do screening for the research purpose for the detection of the chronic diseases as well. Other purpose of the screening can be that it is done for the understanding of the natural history of disease, and it can help healthcare providers for the educational purposes. And even if the disease is diagnosed, the community awareness programs of health education can be done in the community, so that the preventive strategies can be applied in that community as well. Fine. So moving forward, there are multiple different types of screening. Mass screening means you are applying a screening test over the total population. And one of the example is that you make a team of healthcare professionals. You go into the community, you run diagnostic procedure, screening procedure of measuring the blood pressure of a community, and you find out that how many of them there are hypertensive. There will be some people who will be not known hypertensive, and you will be going to diagnose them that your blood pressure is high. So you are going as public health physician to a wider community. You are covering the whole population, and you are going to screen them. Another example can be that you can screen them by the blood sugar fasting levels, or by random blood sugar levels, and if they show abnormal pattern, you can further direct them to undergo the process of glucose tolerance test. Another type of screening is known as high risk screening. And in high risk screening, a specific group is screened. What do we do in mass screening? That a larger number of resources are required, and it is very expensive. It is time consuming that the public health consultant go to a larger population and screens them. So to avoid all these hitches in the screening process, you target only the high risk group. For example, you know that the breast cancer runs in the families. So once the cancer is diagnosed in a female, you can screen the other female siblings, and the cousins, and the other relatives of that particular female, because you think that the genetic material which is shared by all these can contribute towards the development of the breast cancer. So in this case of screening, only the high risk people are targeted. Another example can be that you all know that diabetes is more common in obese population. So instead of going into the population and screening everyone in the population, with the assessment of the blood sugar levels. You do initial screening in which you identify the obese people, and then you do the uh, blood sugar testing of that obese population, which is the high risk population. It saves time, it saves energy, it saves resources, and its yield is more. That the high risk group produces more results as compared to the screening test, which is applied on the general population. Another type of screening is known as multiphasic screening, and in multiphasic screening, the screening is applied in multiple phases. For example, if you go into the community and you do blood sugar random, and on the basis of this blood sugar random, you identify certain people who have abnormal random blood sugar, and then on the another you apply another screening test, which is glucose tolerance test in them, and you follow them over a period of time, that how do they behave, and then you go back, and after a certain period of time you do screening for the detection of the diabetes in that particular group, is known as multiphasic screening. That you are going into the same population on regular repeated intervals for the detection of that particular disease, is known as multiphasic screening. The most important and type of screening which yields more results is the screening of the high risk group. So this is the examples of the mass screening are, for example, if you go into different schools and you do screening for the refractory errors and visual defects. If you go into the community and you do mammograms of the general population, and if you go into the community and you want to do colonoscopy for the occult blood in the community, these are the examples of the mass screening. What are the examples of high risk screening? For example, you all know that with advancing maternal age, the chances of having Down syndrome are more. So, all those females who are more than 35 years of age or 40 years of age, you want to screen their babies in the early part of the pregnancy by alpha fetoprotein detection or by the serial ultrasound for the presence of Down syndrome. Another example, which I have already mentioned, is the presence of breast cancer in the families and the relatives. You can also do screening for hypertension and diabetes in obese population, which is the high risk population. We all know that cancer cervix is more common in those females who have multiple sex partners and who belong to lower socioeconomic groups. So you will target only the lower socioeconomic group for the screening of the cervical cancer. You can target the commercial sex workers for the detection of the HIV in the particular group. So these are the high risk examples of the high risk screening, or the targeted screening, or the selective screening. Then multi-purpose screening means that you are screening one population for multiple tests. For example, if the pregnant women are coming to you, you are going to diagnose this. You want to run the screening test for the venereal diseases. You want to conduct screening for the HIV, hepatitis B, and hepatitis C. It means you want to screen a specific population for multiple diseases. And for multiphasic screening, I have already mentioned that for the first time, you will go into the population, you will check for the blood sugar levels. They can be random, they can be fasting blood sugar levels, and then in the second phase, you want to again monitor them on the basis of abnormal glucose tolerance tests and fasting blood sugar levels. Another example can be that you want to identify the sickle cell anemia, or you want to identify thalassemia in the population. So in the first stage, you will do the CBC, and you will see the abnormal RBCs count in their picture. And if you find any abnormal CBC picture or any abnormal morphology of the RBCs, then you will further make this population to undergo the electrophoresis to identify your diagnosis. So there are multiple types of screening which we can apply in the population. Criteria for successful screening test. There are certain criteria for disease. There are certain criteria for the test. Going towards the criteria for the disease, if you want to apply screening test for a disease, there should be a significant burden of disease. It means that the disease should be present in the population in a very high prevalence. It should be a common public health problem. Number two, there should be a long preclinical stage of the disease. As I have already mentioned you that there in the natural history of disease, before the when the biological process of disease starts and before the sign and symptoms, there should be a gap. If there is no gap, then it will be useless to apply the screening test for that particular disease. Number three, if the natural history of the disease is well known, then the screening tests can be applied. Number four, appropriate screening test should be present for the detection of that disease. Number five, facilities for the diagnosis of the disease. That once you have screened that population, that this particular disease can occur in that population, now you have to subject this population to whom you have identified through screening. You have to apply them to the diagnostic procedures, and the diagnostic tests are available for the detection of the disease. And then there should be outcome benefits, that once the screening is applied, the latent period is long enough that by the early detection and application of early treatment, you can alter the outcome. You can reduce complications, you can reduce disability, you can reduce the mortality rate, and survival rates are increased. And then there should be an effective treatment available, because once you screen a population for a certain disease, and if the treatment is not given to them, then it is useless to apply a screening test in that population. There should be a policy of screening program for a disease which should be funded by the government of that locality, and there should be proper policies that once the population is screened, it should be subjected to the diagnostic procedure and the treatment should be given to that population. And another important thing is that if we are doing early detection, then the cost which is applied for the early detection should be less than the cost which is applied with the late diagnosis and late treatment of that disease. So this is the criteria of the disease. If the disease fulfills all these criteria, then the screening program should be run in the community. Then what should be the criteria of a screening test? It should be inexpensive, it should be easy to apply, it should be simple, it should be acceptable to the population. For example, if you go into the population and you want to do certain invasive tests, the community will not allow you. Even I will give you an example that once we went to the Nansu community and we wanted to check the blood sugar fasting, which actually resulted in a prick and diagnostic test of the diabetes mellitus. The community was not very happy and they were reluctant for that prick. So whenever you want to conduct a screening test in a community, it should be acceptable to the population. It should be valid. It means it should measure what it requires to measure in that population. It should be reliable. It means once the test is applied in the same community again and again, it should produce the same results. The results should not change. And then in the end, the screening test should actually give a high yield, that it should detect the true positives in the population who are actually diseased in that population. So I think I will finish here and we will move forward with the screening in another lecture, because I think if I will teach you more than this, you will not absorb this. So if you have any questions, you are more than welcome to ask me. Please go through the chapter of screening from your textbooks, and I'm always here to answer your questions. Thank you so much.